Here at the Baby Channel, we're proud of the huge array of doctors and midwives that we have on hand to deal with your medical queries. Today, Dr. Alison Taylor, a consultant gynaecologist from the Lister Hospital, is here to talk about assisted conception. Hello, thanks very much for coming in. Well, first of all, tell me, what is assisted conception?
Assisted conception covers a whole range of different treatment options for people that are having difficulty getting pregnant, and all of them are designed to try and obviously enhance the chance of pregnancy occurring. And in general, what they do is they tend to bring the sperm and egg closer together to a greater or lesser extent. And for example, they include things like intrauterine insemination, where you actually place a sperm sample into the uterus and often combine it with some stimulation of the ovaries to make sure there's at least one egg available for the
so it doesn't all have to take place outside of your body?
No, not necessarily. So that's the sort of simpler end of the spectrum, and then there are more complex treatments like in vitro fertilisation or IVF, where you're literally placing the egg and sperm together in a dish in a laboratory to encourage fertilisation to occur and then putting embryos back. But it also encompasses some other treatments for couples where there's perhaps no sperm or no eggs available, so things like donor insemination and egg donation as well.
So it's all of it, really? Anything that doesn't naturally occur that you need any kind of help with becomes assisted conception?
Yes, really. Although there are some things like treating ovulation problems, perhaps doing tubal surgery that we wouldn't generally class as assisted conception techniques.
Right, but hopefully have the same result.
Hopefully, yes.
Everybody's after that baby.
All with the same aim at the end of the day, yes.
And what would you say are the indications for the different types of treatment? How do you know which route you'd need to go down?
Well, it'll usually start once you've actually had some investigations, which we've talked about previously, and then you sit down with a couple and try and work out what's the best plan of treatment for them as a couple, looking at where the specific problems arise. Things like intrauterine insemination, which are a very simple type of treatment, are generally really used for couples where there aren't any obvious reasons found for a delay in achieving a pregnancy. Right. Whereas IVF started off being used for women that had badly damaged tubes as a way of overcoming the tubal blockage.
So just bypass the problem.
Exactly, completely bypassing the bit that takes place in the tube, which is the fertilisation of the egg and the early embryo development. You're taking that out of the body, doing it in the lab, and then going back to the uterus for the bit where implantation would occur.
If that's the case, would you then put 2 embryos back in, or would you just put 1?
More commonly, we put more than 1 embryo back. In this country, in women under 40, we're not allowed to put back more than 2 embryos, whereas in women who are 40 and over, we can put back up to 3 embryos. But there's quite a big concern now about the risks of multiple pregnancy, not only twin pregnancy, but particularly triplet pregnancies. So we try very hard to minimise that risk.
So triplets can be more likely now?
Yes, they would be, particularly in younger patients. If you're putting back good quality embryos, then yes, that risk becomes really significant.
And that's an awful lot to think about, isn't it? From going from wanting 1 baby to having 3.
Absolutely, but probably more importantly, and some patients think if they get twins or triplets, well, it's great because actually you've got 2 or 3 for the price of 1, and considering a lot of them are having to pay for treatment, then they perhaps think that that's a pretty good deal. But actually, because of the complications with multiple pregnancies, it can be difficult, and they actually may end up not having live children at all. They may have babies that are lost in miscarriage, or babies that have died because they're severely premature, or they may have survived but actually have significant health problems and long-term developmental problems.
So it puts huge pressure on the whole process.
Absolutely, and on the family that's then left dealing with all the problems long-term.
The emotional trauma of that.
Yeah. But just coming back to the IVF sort of indications for IVF, it started off being a treatment designed to overcome tubal problems, but now is commonly used to treat a whole host of different fertility problems, and not least of which are male factor problems, so problems with sperm counts. And it's really one of the most practical ways of getting round that difficulty.
How would you describe the IVF cycle? I mean, quite simply, what happens?
Well, it's made up of a number of different steps during a treatment cycle, and the first bit usually involves some drug stimulation of the woman's ovaries to try and deliberately get her to produce several eggs in the one treatment cycle. In a natural cycle, we will usually produce 1 egg per cycle, sometimes more than 1, but usually 1. In an IVF cycle, we deliberately stimulate the ovaries to try and get several eggs to grow all together and grow to maturity. And then when we've got several eggs growing. We monitor them using ultrasound scans and blood tests, and then the next step is to actually get those eggs out of the ovary in what's called an egg retrieval or egg collection procedure. And
the woman can be awake for this procedure?
Well, yes, they usually have some sedation, as minimum. You can do it without. I have known the odd patient who has requested to have it without any sedation at all, but in general most patients would prefer to have sedation or a light general anaesthetic for it. It's not a long procedure. It normally takes about 15 to 20 minutes, and it's done vaginally now. It's not involving any surgery on the tummy, on the abdomen. It's all done from below using an ultrasound scan.
And of course you recover from that so quickly, don't you?
Yes, I mean people are often a bit uncomfortable and aware of their ovaries, a bit sore afterwards for a few days, but nothing too terrible.
And it's not the same as having an operation where you've been cut in?
No, not at all. So we actually guide a little fine needle into the ovary where the eggs are developing, suck the fluid out of the follicles, these fluid-filled sacs in the ovaries where eggs are developing, and the fluid comes along some tubing into a test tube, and that's where the sort of test tube baby name of the treatment comes from.
I see.
And then we take those tubes, are then handed on to the laboratory staff, the embryologists, and they look at the fluid under the microscope to see whether or not there's an egg there. So that's how we actually get the eggs into the laboratory and out of the ovaries. And then the next bit, which is common actually to pretty much all assisted conception techniques, is getting a sperm sample and preparing it. So we don't just take the neat sperm sample that's produced by the man and put it with the eggs. We actually put it in a test tube and then spin it down and put it through a special preparation which will help to select out the sperm that are the most normal and are moving the best, because those are the ones that are going to have the best...
The good swimmers.
The really good ones, absolutely. The ones that are going to have the best chance of fertilising eggs normally.
And you said spin it down. What did you mean by that?
It goes into a centrifuge, which literally does spin the tubes very, very fast.
Right.
And it helps to get the best sperm into the bottom of the tube. And then you can discard the top bit of the tube, the fluid, keep the very best ones, and then there's more washing processes that go on to concentrate the best sperm that are there. But basically, there's a little droplet of that concentrated good sperm is then mixed together with the eggs and left in the incubator overnight at body temperature to see whether or not the eggs will fertilise.
So there's, that's nature going on there, isn't it? Just in a different circumstance.
Yes, but just in the sort of, scientifically controlled environment in the laboratory to try and make it as similar as possible to what's happening in the normal situation.
But I like the idea of you leaving them alone together overnight.
Yes.
See what happens.
Yes, and then the following morning we have to actually see whether anything has happened, and so the embryologist will have a look at the eggs and see how many of them have fertilised. And we wouldn't always expect all of them to fertilise. Sometimes you get all of them, sometimes you get none of them, but usually it's about 2/3 to 3/4 of eggs will actually fertilise. And having started off with hopefully a reasonable number of eggs, and the average number of eggs in a cycle would be 10 to 12 eggs, we would then, if we've got some fertilised, have a choice of fertilised eggs and embryos that are going to develop over the next few days. And it's from those embryos that we will then try and select the best two, usually, to go back into the uterus.
Is it obvious to your scientific eye, or is it not?
It's the embryologists in the lab that do that. It wouldn't be me as a clinician, but they will do that by looking at the way the embryos have developed over those few days that they're in the incubator.
Right.
We know that embryos should develop at a particular rate. So when the fertilised egg, which is just one round cell, first of all pinches into two cells.
But yes, and start that dividing process.
Then that's right. And then by the sort of second day after egg collection, those two cells will have divided again, should have done into 4 cells, and so on. And by the third day, they should be sort of getting towards the 8-cell stage. And many, many human embryos actually are quite slow in development and will begin to stop. They're not all capable of going on and making a pregnancy. So what you're looking for are the ones that are carrying on at the right rate of development, and also, as they're dividing, not just breaking down into lots of little pieces, which are called fragments, but keeping nice whole cells that look really regular and round.
Well, you've described that beautifully. I mean, it sounds as if it would be quite obvious which ones.
Sometimes it is. Sometimes it is, and sometimes it's less easy to tell, because you can also have the most beautiful looking embryo which you put back and doesn't necessarily make a pregnancy. So it's not always guaranteed.
No, you can't control the whole process, but
no.
Huge guiding hand. One of the questions that we've got in is that I've heard embryos can be frozen, but doesn't this mean the embryos can be damaged?
Well, it is certainly quite an insult to such a tiny, delicate structure, because we've got to remember that we're talking about embryos that are about 1/10 of a millimetre in diameter that we're handling, and to freeze them is really quite a big insult to them, yes. And some embryos certainly won't survive being frozen and thawed out. So in general, most units will be quite selective about which embryos they freeze, and they need to be pretty good quality ones, top quality, to stand a reasonable chance of surviving freezing and thawing out. But if they do survive, then they will have a chance of making a pregnancy, and there's certainly no evidence that if a pregnancy results after using frozen embryos, frozen thawed out embryos, there's no increase in risk of abnormalities or anything like that from those pregnancies that result. So it's well worthwhile, if patients have a good number of good quality embryos, to freeze some, so that if they get pregnant in that cycle, great, that's fantastic, then they can come back later on and have perhaps number 2 from the frozen embryos.
Yes, they wouldn't have to go through
all the stimulation and everything. Or if it doesn't work out with that first fresh attempt, then they can have another attempt with the transfer again, as you say, without going through all the stimulation and the invasive bit, which is the egg collection.
Another viewer has written in and asked what are the associated risks with assisted conception treatment?
I think that's a really important question, and it's something that patients are often quite worried about. The main risks of the actual stimulation from the woman's point of view is that some women's ovaries are very, very sensitive to the drugs and can produce very large numbers of eggs. So although I said the average might be 10 or 12, some women will readily produce 30 or more eggs.
Oh my gosh, that's shocking.
And their ovaries will go from being something that's sort of about 3 centimetres in length to being like little footballs in their abdomen. That certainly is uncomfortable with them being that enlarged, but probably more important than that is that the very high hormone levels that are associated with those very big ovaries means there's peculiar shifts in the body of fluid, and they can tend to collect a lot of fluid in their tummy and in their chest in the really severe cases and need admission to hospital. So it's very important to monitor the cycle really carefully to try and reduce that risk as much as possible, and be cautious with the dose in women that are likely to respond a lot.
People going down that road know that there will be bumpy times ahead.
Yes.
So I would have thought they'd be slightly prepared for it not to be as smooth going.
I think it's really important that when they go through treatment that they have time to sit down and hear about the things that can happen at different stages, because I always try and tell patients that it's like a sort of series of hurdles to get over. The first one is the stimulation, and getting that just right with a nice number of eggs, not too few, not too many. Then will they get eggs out of the follicles that are there, because that doesn't always happen. If they get eggs, will those eggs get fertilised? That's the next sort of hurdle to get over. And then will the embryos actually divide and develop appropriately and get to the point of having embryo transfer?
Each stage brings a challenge, doesn't
it? Definitely.
Yeah. And your hopes are raised and kind of dashed, but...
And that's why patients will often describe it as like a sort of real emotional roller coaster, each of these hurdles to sort of get over.
Well, thank you for explaining some of how it works. I know that we're going to see you again, and you can answer some more questions. We often have a lot on this subject. Alison, thank you very much for making it so clear.
Not at all. Thank you.